Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a cataract with Coloboma iris and Coloboma choroid. Let us observe this surgery. It is minimally edited. The ocular surface is thoroughly irrigated, applying few drops of povidone iodine, and now the main incision is to be placed. I take a 2.8 millimeter steel keratome and place the main incision at around 11 o'clock on the posterior aspect of the limbus. And now, the anterior chamber is filled up with 2% hydroxypropyl methyl cellulose. A side port is made on the left side of the main incision about 3 clock hours away. Now, Capsulorhexis is to be done. Using a utreta forceps, raise a capsular tag and do the rhexis. We must remember that the rhexis should be, about 5.25 millimeter. We cannot do a large rhexis in such cases because we may need a capsular tension ring. And now hydrodissection is done. And since the cataract is soft, my plan in this case is to divide the nucleus using a pre-chopper. The anterior chamber is filled up with 2% HPMC. And now I am taking the pre-chopper that was designed by me. The pre-chopper has a cutting edge, front cutting edge, and a blunt back edge. It goes through the main wound. Through the side port goes a nucleus sustainer. The two instruments come to each other and we get a very nice crack. One more crack. And now I fill off the anterior chamber with visco and take the pre-chopper again. The nucleus sustainer hooks the equator of the heminucleus that is not yet divided, and then I divide this heminucleus. So the nucleus has been divided into 4 pieces. And now we're going to remove the pieces. Bottle height has been reduced to about 55 centimeter. And now the handpiece is introduced with 2.8 millimeter easy tip of Oertli. The machine is Oertli Catarex 3. The handpiece goes with its bevel down and then it is turned to make the bevel sideways. And now I am picking up the pieces which is near 12 o'clock. I keep the last piece inferiorly so that it keeps on supporting the area where the jonule is weak in the colobomatous area. The handpiece is used to remove a portion of the cortex. And now I inject visco, fill up the anterior chamber as well as the capsular bag. And now I am going to remove the cortex. And now is the time to implant the intraocular lens. The anterior chamber as well as the capsular bag is filled up with 2% HPMC. And now the lens is injected in the capsular bag. Let's see what is happening. The lens has been loaded. It's a preloaded lens, and it has come in this way, upside down. So I have to rotate the lens so that it is in the correct orientation. I take two hooks and turn the lens. And now the lens is in the correct orientation. This is a Rayner hydrophobic intraocular lens. Rayner, the company who made the first intraocular lens in the history of intraocular lenses. And now my plan is to do a small sphincterotomy at 12 o'clock pupillary margin. In this case, I saw in the pre-op that the pupil is very small and the pupillary margin almost obstructs the visual field, visual axis. So my plan is to do a small sphincterotomy. And I'm cutting it just up to the collarette. Now the pupil will be a little updrawn and it will help in bringing the rays of light to the fovea. And now I remove the visco, and then my plan is to check if there is any vitreous strands in the anterior chamber. So I inject triamcinolone acetate, and I find that there is no vitreous strands. And now another lavage by bimanual IA so that all the viscoelastic substance comes out. And now is the time to conclude the case. Before that, this is moxifloxacin. The side ports are closed by stromal hydration. The main wound will not require any hydration. final lavage with a 23G Simcoe. The antechamber is nicely formed. Integrity of the wounds are checked and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence.